Under tourniquet, the standard anterior medial and anterior lateral portals are created, and the joint is insufflated with normal saline. Depending on the location of the osteochondral lesion, a posterior lateral portal may be necessary to best visualize and prepare the defect. The first portion of the procedure involves performing a diagnostic arthroscopy, and the ankle is evaluated in a systematic fashion. As seen here, a fissure is identified along the lateral shoulder of the talus, consistent with an osteochondral lesion of the talus. Loose fragments of bone and cartilage are removed, and a stable rim of cartilage is delineated with a sharp curved curette and shaver. The defect is measured with an articulated probe. We measure the length, width, and depth of the lesion, and the need for bone graft and/or cartilage transplantation is determined. Once the bed of the lesion is adequately prepared, a dry arthroscopy is performed. Excess fluid is removed, and the ankle is completely dried with the use of 1/4-inch pledgets. Meanwhile, the juvenile cartilage graft is prepared on the back table and loaded into a 4mm cannula. Once the cartilage allograft is prepared and hemostasis is maintained, an 18-gauge needle is utilized to place a layer of fibrin glue at the base of the lesion. The cartilage allograft cannula is introduced into the ankle with the opening at the most posterior edge of the lesion. The graft is slowly extruded such that a column of allograft is seen. The distal aspect of the column is placed into the fibrin glue, and this is repeated until the lesion has been filled. A freer elevator can be used to shape the graft as appropriate. A second layer of fibrin glue is then introduced over the graft to seal it in place, and the ankle is left in traction until the glue has set. Post-operatively, we splint the ankle for 10 days, then begin early active range of motion, and the patient must remain non-weight bearing for 6 weeks.